So, good morning to you all. So, we start the second session on pre-paper in vitro retina, and I have with me Dr. Karobi, who is the chairman, and we have also the moderator, Dr. Manoj. Each paper 6 minutes, 2 minutes of discussion. Please keep up with the time. That's very important.
I will call the first presenter, Dr. Samira Nayak. She will be presenting on outcome of universal eye screening of newborn in tertiary healthcare system.
Slide change, sir. There's one paper.
Yes, Dr. Samira, please.
We are taking Dr. Samira early because she has a small baby to cater to. So, with the permission of all the people and the presenters here, we are asking her to present first.
A very good morning to all. We know retinopathy of prematurity screening has fixed protocol, fixed guidelines. But what about babies who do not fall into ROP screening criteria? Are they all normal? We often see sight-threatening pathologies in newborn like congenital cataract, congenital glaucoma, endogenous endophthalmitis, retinal hemorrhages, and vitreous hemorrhages. With this backdrop, we did a prospective study titled Outcome of Universal Eye Screening in a Tertiary Eye Care Center in South India from April 2016 to March 2018 in 2 hospitals, a medical college and a corporate hospitals to include all types of babies. The objectives were to know the different ocular pathology of newborn and associated perinatal risk factors. All these babies were screened within 7 days of birth. We took detailed perinatal history, maternal as well as fetal history. A comprehensive eye examination was conducted by a trained pediatric retina specialist using 28 diopter lens and binocular indirect ophthalmoscopy. Appropriate statistical analysis was done using Stata 13. In this study, we included 1,795 newborns. Median paternal age was 28.3. Maternal age was 23.7. Birth order was 1.8. Median 10-minute Apgar was 8.5. Median age at screening was 2.67 days. 18.2% babies had some type of ocular pathology, the commonest being retinal hemorrhage. Other sight-threatening pathologies were vitreous hemorrhage, endogenous endophthalmitis, of prematurity screening has fixed guidelines, protocols. What about babies who do not fall into ROP screening criteria? Are they all normal? We often see sight-threatening pathologies like congenital glaucoma, congenital cataract, endogenous endophthalmitis, vitreous hemorrhage in newborn babies. With this backdrop, we did a study titled Outcome of Universal Eye Screening in a Tertiary Eye Care Center in South India from April 2016 to March 2018. It was conducted in 2 hospitals, a medical college and a corporate hospital. The objectives were to know the different ocular pathologies of newborn and associated perinatal risk factors. All these babies were screened within 7 days of their birth. We took detailed perinatal history, maternal and fetal. A comprehensive eye examination of the baby was conducted by a trained pediatric retina specialist. Appropriate statistical analysis was done using Stata 13. In this study, we screened 1,795 newborns. Median paternal age was 28.3, maternal age was 23.7, birth order was 1.8, median 10-minute Apgar was 8.5, median age at screening was 2.67 days. The 18.2% babies had some kind of ocular pathology, the commonest being retinal hemorrhage. Other sight-threatening pathologies were vitreous hemorrhage, endogenous endophthalmitis 4 in number, congenital cataract retinopathy, ROP light retinopathy, etc. We did a multivariate analysis to know the associated risk factors, and we found retinal hemorrhages were associated with normal vaginal delivery with odds 10.1, and non-RH pathologies were associated with prematurity, consanguinity, low birth weight, and systemic abnormalities. 12% babies had some kind of systemic abnormalities. There was no adverse events during examination of these babies. So in conclusion, commonest ocular pathology in otherwise healthy newborn was retinal hemorrhage, which was usually got resolved in 3 months follow-up visit. Sight-threatening ocular pathology in otherwise healthy newborn was not uncommon during universal eye screening, which could be associated with prematurity, low birth weight, consanguinity, bad obstetric history, and systemic abnormalities. Universal eye screening may not be feasible in a populous country like India. So we propose to have a targeted eye screening of the newborn, so that instead of screening all the babies, if we can target the babies with risk factor of prematurity, low birth weight, and consanguinity, and bad obstetric history, then we could find sight-threatening ocular pathology. We can detect early and treat them early. Earlier, we knew that as per Rashtriya Bal Swasthya Surakha Karyakram, we have red reflex test to screen all newborn babies by the pediatrician. But red reflex test is sensitive 99% to detect anterior segment pathology, but it is not very sensitive to detect posterior segment pathology. So a detailed comprehensive eye examination for newborn is required, which may not be cost effective for a populous country like India, sparing a retina specialist or a pediatric ophthalmologist. So we propose to have a targeted eye screening of babies with risk factors to intervene in avoidable blindness. Thank you.
Thank you, Samira. I just had one question for you. In your group of 5 babies, you have not really mentioned that newborns means preterm newborns or they are full-term newborns. That segregation is not there. Then there seems to be a little bit of a mix-up between what you say is newborns with ROP-like features or non-ROP-like features. And so could you just segregate that for us, please?
Yes. So in this cohort, we have 1,565 full-term babies and 230 preterm babies. Preterm babies who do not fulfill ROP screening criteria. So between 34 to 37, they are also included under prematurity. So 34 weeks gestational age to 37 weeks gestational age. As for ROP screening guidelines, we need to screen less than 34 weeks or equal to 34 weeks and 2 kg or less than 2 kg babies. So between 34 to 37, we still consider them as preterm babies, but they do not fall under ROP screening criteria. And in this cohort, am I clear, ma'am?
Yeah, but I mean,
So in this, we
see-
have.
Okay. No, I mean, just to add on to what Karobi said is, I mean, just to improve the paper, I think birth weight is very important. Birth weight is very
Yeah,
important, which you have not mentioned in your.
Can you
this-
project this slide? I have hidden purposefully
No,
one
birth
slide.
weight. No, I'm just telling you. Whatever I saw only, I can
This
tell
is
you.
the baseline characteristics.
Birth weight is important, and correlating birth weight with some of the abnormalities that you have seen, because ultimately you are saying that there is a higher risk in people with low birth weight, with the systemic abnormalities, etc. It will be interesting if you could, in your results, try to correlate those features with the birth weight, etc., so that you're able to get a better understanding.
Yes, sir, we have correlated. Can you project the slide? Is there any problem? We did a multivariable analysis keeping prematurity, birth weight, weight, gestational age, and bad obstetric history, SpO2. All factors are actually we taken into consideration. We did a multivariable analysis, and we found that prematurity, low birth weight, bad obstetric history, suppose a mother is having more than 2 abortions, and babies with systemic abnormalities. All these factors are significantly associated with some kind of ocular pathology.
Okay.
So the odds are more. We did a multivariable analysis, but other factors like maternal age, paternal age, and suppose there are other factors. So those are not significantly associated. So finally we found that.
If I can interject, Samira, I think you have to segregate your paper. Your paper is not clear at all, because what happens is that you have mentioned there are hemorrhages in people who had vaginal deliveries. That's not anything new. Because the child is coming by the vaginal route, you do get hemorrhages. Whereas the other things you have to segregate, whether the patient has anemia, the patient has sepsis, what is the reason for the endogenous endophthalmitis, what is the reason for the vitreous hemorrhage, is there any kind of blood parameters. All these segregations have to be done. You cannot only blame it on bad obstetric history or whatever,
We have segregated the entire cohort into 2 groups. One, pathology, only retinal hemorrhages, and non-RH pathologies. So RH pathology like retinal hemorrhages is associated with normal vaginal delivery, we knew earlier. Non-RH pathologies like endogenous endophthalmitis, cataract, glaucoma, other things are associated with prematurity, low birth weight, consanguinity, and bad obstetric history that we found in multivariable analysis.
Okay.
Thank you.
Dr. Harshita Nahata. Is she available? Yeah.
Morning, everyone. I'll be presenting a paper on is type 2 macular telangiectasia or MACTEL a bilateral and symmetrical disease entity. My chief author is Dr. Ramesh Venkatesh, and I have no financial interests. So as we all know, type 2 macular telangiectasia is actually an acquired bilateral neurodegenerative disease which is associated with reduction of macular pigments like lutein and zeaxanthin with secondary vascular changes. It has a slowly progressive central vision loss with foveal atrophy and a neovascular membrane proliferation. The currently accepted staging was given by Gas and Blodys in 1993, wherein stage 1 has been defined as occult telangiectatic vessels identified as late phase temporal perifoveal hyperfluorescence on FA, and the entire staging was given on the basis of finding of fluorescence angiography and other imaging modalities. Now, the current understanding of the pathomechanism says that the bilaterality is a characteristic of type 2 MACTEL. There are very few case series in literature which comment about its unilateral or asymmetric presentation. There was a large-scale study conducted by the MACTEL study research group, wherein baseline characteristics of eyes were studied, and they only mentioned asymmetry. Now, the lacunae in current literature which exist are that the microvascular changes on OCT angiography occur before visible structural changes on OCT in fellow eyes of asymmetric mactal patients. But none of these literature studies, they used angiography to describe stage 1 of the disease, as was actually originally described by Gaston Lodi. Also, there's a lack of literature on the asymmetric distribution of the disease and limited information regarding the prevalence of asymmetric distribution and disease stage asymmetry between the eyes. Thus, in this backdrop, we decided to study the prevalence, demography, and clinical features of type 2 mactal cases, showing inter-eye disease stage asymmetry at presentation and at last follow-up. Also, we evaluated cases of mactal wherein what we described as an apparent unilateral disease. Ours was a retrospective single-center study wherein bilateral good quality imaging cases were included, and we studied the clinical features, multicolor imaging, OCT angiography, and fundus fluorescent angiography in selected cases. As we all know, mactal, as described by multicolor imaging and OCT in these images, shows intraretinal pigment clumping, loss of retinal transparency, and in late stages, a neovascular membrane beneath the retina. Also on OCT angiography, here you can see as in a temporal loss of a temporal perifoveal graying, which can be seen, and an abnormal vasculature, which is seen more so on the deep capillary plexus layer, but can extend up to the choroidal slab also. Our results showed we studied 280 eyes of 140 patients, wherein 84 had a symmetrical mactal, whereas 56 had asymmetrical mactal presentation. And mostly we saw that there was a difference. We found the majority of cases in our study, they fell into the stage 2, and there were 15 eyes which did not show features of mactal on clinical examination. 3 eyes lacked features of type 2 mactal clinically and OCT, but showed classical perifoveal characteristics on angiography. So we labeled these eyes as stage 1 type 2 mactal. There were another remaining 12 eyes, wherein on angiography, OCT angiography, there were no features which have already been described, but the fellow eye showed some stage of mactal. This we described as unilateral type 2 mactal. There was a 2-stage difference seen at presentation in 26 eyes and at last follow-up in about 8 eyes. Asymmetrical groups had statistically significant better visual acuity compared to symmetrical group, but not so in the advanced stage. The visual acuity at presentation in the asymmetrical group was compared to the visual acuity from the symmetrical group even at the last follow-up. Approximately half of the patients showed a 2-level stage difference between the 2 eyes at presentation as well as follow-up, and less than 5% of the patients showed a 4 or 5-level difference. Now, this is one of the patients from our study, which was a 58-year-old male diabetic who had right eye, as you can see, in absolutely normal fundus, whereas the left eye shows a pigment deposition and loss of transparency of the retina. Similar findings were also corroborated on the multicolor imaging. On the OCT, you can see the right eye is absolutely normal without any stage change, whereas the left eye shows the subretinal neovascular membrane proliferation. Same findings were noted on the angiography also. And OCT angiography, herein you can see the right eye, there is no network of vessels seen on any of the slabs, whereas in the left eye, the superficial and deep capillary plexus both show an abnormal vascular change at the foveal avascular zone, which is extending up to the choroidal slab. To conclude, despite being commonly thought of as a bilateral symmetrical disease, mactal type 2 can exhibit inter-eye disease stage asymmetry as well as disease asymmetry. We also added a unilateral type 2 mactal disease as a separate stage which needs further investigation. We also propose a new staging, which is the unilateral disease, as I already described earlier. The strengths of our study was a large cohort of cases from a single center, so there was consistency in imaging across different centers, and we could also assess the longitudinal data of all of our patients. The main drawback was it was a retrospective study, so all follow-up visits could not be assessed. Thank you.
Yeah, I mean, good presentation. Couple of things what I want to tell you is, number one, unfortunately we can't call.
Yes.
because confocal blue reflectance.
Yes.
If you do CBR, even in the normal eye,
Yeah.
you will see increased reflectance. That is the earliest sign. You understand? OCT is normal, but CBR will show you increased reflectance. That is the earliest change in multimodal imaging.
Okay.
If you leave OCTA, OCTA is unfortunately a very difficult modality to interpret.
Yes.
So, but CBR will definitely be affected. So that's why we cannot call it, using multimodal imaging, you cannot call it unilateral.
Yeah.
In the case that you showed gross asymmetry, if you see the color photograph itself, there is slightly increased parafoveal reflectance is there. Little
In
bit
the right
parafoveal
eye,
reflectance
yes,
is there.
yes.
Therefore, you can easily say that there is
Yeah.
Third thing is that we have also reported the presence of hyperreflective dots in one of our papers, which were published about 1.5 years ago, in eyes with normal OCT. I mean, beautiful hyperreflective dots. We don't know whether they are Muller cells, degeneration, or whether they are photoreceptor cells that are just being released. We really do not know. But characteristic hyperreflective dots, even in eyes which are normal in OCT. But it's a good observation. Now, how many years follow-up do you have for the eyes with near normal OCT? How many years follow-up?
So, starting from the minimum we kept as 6 months to we have up to 44 months of
44 months.
yes.
And
follow
during the
up.
period of 44 months, did you see any change in the normal eye?
In the normal eye, yes, sir, there has been a conversion. The patients who did not have, which is also one of the reasons we want to state this, because those eyes are the ones which actually need to be followed up more closely than the one which already is in a stage. We had also thought
Which eye was more commonly affected, right eye or left eye?
So left eye.
Left eye was
actually,
more
yes.
commonly, because there is a recent paper that has
Yeah.
been published where they have shown that something to do with the circulation. I mean, it's a speculation
Yeah.
that basically carotid artery circulation itself is probably one of the reasons. That is, the blood supply is more through one side than the other side, and that's why asymmetry comes more commonly to one side.
Yeah. So this change actually, whether right eye or left eye, this was not significant in our paper, but the MACTEL study group, which I stated, which was studied, I think, in 2005 or something, they had stated that they found significantly more in the left eye actually than us.
This is right eye.
Yes,
Yours
sir?
is right eye.
No, in ours also it's left, but the data was not significant as such for the left eye. We also actually thought, sorry, ma'am, you can please. We also thought of giving a stage 0 instead of a unilateral staging, but we did not have angiography images of all patients. One modality which actually we lagged was autofluorescence also for all patients. So that's why instead of calling it as a stage 0, we decided to call it unilateral, basically.
And in your 44 months follow-up, did you find any patient who you said earlier was unilateral turned to bilateral?
As in one side, okay, yes, ma'am, we did find that. Initially, there was no stage as such which was described by the gas and bloaty staging, but eventually they ended up having MACTEL in the other. But then that we were able to notice because on all visits we were imaging both the eyes, which normally is not the case when we follow up such patients.
And what was your follow-up period like?
6 months to 40. This was a retrospective study, ma'am. So we went back and looked at these patients. So we found 44 months up till the imaging was available. Okay, thank you so much.
Good morning, everyone. I will be presenting on subretinal hyperreflective globule in cases of central serous chorioretinopathy. So central serous chorioretinopathy is a chorioretinal disorder which is characterized by serous retinal detachments involving the macula. There may be focal pigment epithelial detachments, choroidal hyperpermeability, and increased choroidal thickness. Advances in imaging have led to the discovery of novel OCT features in retina and choroid, which could be potential disease activity biomarkers. So the aim was to describe subretinal hyperreflective globule in cases of CSCR. This was a retrospective study which covered the time period from January 2021 to March 2022. So all patients of CSCR who had come to the OPD were included, and according to the examination and investigations conducted, they were classified as acute, chronic, and resolved cases. Any cases with media opacities, pre or coexisting macular pathologies, and inadequate image qualities were excluded.
So subretinal hyperreflective globules were thought to be lipid globules. They were found to be situated in between the retinal pigment epithelium and the external limiting membrane or the ellipsoid zone. They are characterized by a hyperreflective core, a hyperreflective border, and a posterior tail of hypertransmission as shown by the yellow arrow. So overall, the mean age in years was 43.27. There was a male preponderance, with the right eye being more involved than the left eye, and the mean subfoveal choroidal thickness was 379 microns. So 137 eyes were included, and out of 80 cases of acute CSCR, only 2 had this SHG, whereas 25 out of 49 cases of chronic CSCR had SHGs, and 3 out of 8 resolved cases had the same. So eyes with and without SHGs were compared in acute and chronic cases, and it was found that the prevalence was more in the older age group, in cases having a higher subfoveal choroidal thickness, in chronic cases over the acute cases, and in cases where sciatic retina was present. So there is a daily outer segment shedding of the photoreceptors, and this is processed by the retinal pigment epithelium, and the lipids along with the carrier lipoproteins are transported to the bloodstream. If there is any alteration in this pathway, this will lead to the accumulation of lipid in the retinal pigment epithelium, and lipids in an aqueous environment tend to form a sphere, hence giving rise to the globular appearance. So this lipid globule has several characteristics, such as it has a small diameter, it has a higher refractive index than the surrounding retinal tissue, it is optically clear and spherical in shape. This will give rise to a lensing effect. So overall, the incoming light is minimally absorbed and negligibly attenuated, and there is maximum transmission of light to the underlying choroid and sclera, hence giving rise to the posterior tail of hypertransmission. So such a similar feature is also seen in cases where spherical objects with a lipid bilayer is present, such as trapped silicone oil bubbles, atheroma with a necrotic core, and adipocytes. So recent studies have suggested that there is a deranged lipid metabolism in CSCR. Subretinal fluid in CSCR was analyzed, and it was seen that there was an upregulation in the liver X receptor pathway, which is involved in cholesterol metabolism, and a downregulation of the biliary acid metabolism. So both of these combined may have given rise to the SHG in CSCR. So Fernandez, Avellaneda, and colleagues have recently described such a finding in eyes receiving intravitreal anti-VEGF in neovascular age-related macular degeneration. So this is the first report of SHG being studied in CSCR, and we see that it correlates with the chronicity of the disease process. So to conclude, subretinal hyperreflective globules are mainly seen in cases with chronic CSCR with thick choroid, which suggests an underlying inflammatory process behind their formation, and it may emerge as a possible biomarker in the future for disease chronicity. Thank you.
Good presentation. Over to you, Sangeet, for any questions.
Of these globules.
Yes, sir. Like with the chronicity, like it can be used as a biomarker, as in especially in resolved cases like the chronicity, the thickness of the choroidal, the thickness of the choroid, and
it is because of the chronicity, or like it can be in an acute stage, and you can pinpoint that this CSR is not going to resolve and it's going to be chronic.
Sir, we need to study it further actually, because right now there were only 2 cases of out of 80 cases of acute CSI which just had this finding, and majority of the cases were chronic cases. So
like you underwent other investigation, like you were seeing liver and other things. So do you think other like metabolic other changes also can affect all these things?
sir, basically like one is RP dysfunction.
Please talk into the mic.
Sorry, sir. So one is the pathway that I described, that photoreceptor lipid shedding. So if there's some RP dysfunction, that can lead to the accumulation of lipid globules. And another one, the SRF fluid, which was the analysis which was done. So according to that, the deranged lipid metabolism in CSCR was found so far. So
I mean, the thing is, I mean, from as a continuation what Sangeet said, interesting observation.
Thank you, sir.
But then how do you define chronicity? I mean, because this word chronic is a very vague term. How do you define chronicity? Because your OCTs are normal, isn't it? The OCT doesn't show any evidence of chronicity. So how do you define chronicity?
Sir, in chronic CSR, like the foveal thickness, and if there's any presence of sciatic retina and
I
the
think
period
autofluorescence is very important because in CSCR, if you want to really, I mean, one of the most sensitive tests that you can do to say whether it's a chronic case or it's a recurrent case or a patient who's been having repeated episodes, the best of all the multimodal imaging that we have, probably autofluorescence is the most sensitive because it will show you patches of complete decreased autofluorescence. You understand all this to tell you that yes, this patient has been having, or patches of decreased autofluorescence to tell you that the patient has been having repeated episodes. You understand? So that is a more sensitive test than these sort of very minute, details that we are seeing. It's an interesting observation. I mean, from the point of view of observation, it's very interesting, and probably time will tell whether these things are really very important in the, I mean, in the understanding of CSCR. You understand? So when you're telling these things, you will have to also correlate as to the other features. That is, if you see 10 patients, in these 10 patients, you'll have to say how many of them have had multiple episodes. You understand?
Yes.
How many of them have had episodes which has lasted for more than 6 months, etc., to generally define as to what sort of cases you're able to see these sort of changes.
Yes, sir.
Okay, thank you.
Thank you.
We'll call by Dr. Atul Puthalnath. He is present. Okay, he will be presenting pediatric endogenous endophthalmitis insight and revelation from a therapy care center of tertiary care center from South India.
Good morning, respected judges and my dear colleagues. I'll be presenting on pediatric endogenous endophthalmitis, insights and revelations from a tertiary care center in South India. As we know, incidence of endogenous endophthalmitis varies from 2 to 8%, and pediatric endogenous endophthalmitis has been reported 0.1% in US and 4% in India. The least common cause of endophthalmitis in children is endogenous endophthalmitis. The other type of endophthalmitis are more common, usually seen in premature infants, infections, prolonged hospital admissions, and inborn errors of metabolism. So we did a retrospective study of electronic our EMR records. 21 eyes of 21 children were used at a tertiary hospital during the period of 2014 to 2020. So we included signs and symptoms of any patients presenting with endogenous endophthalmitis, children less than 15 years. We did not include cases which had recent ocular trauma, ocular surgery, or previous recently documented inflammation. The history we collected included febrile illness, recent infection, hospitalization, and we subjected the children to visual acuity logMAR or torchlight examination depending on the age of the child, slit lamp evaluation, fundoscopy, and B scan in which the fundus was not visible. Vitreous tap or vitreous biopsy were collected, and microbiology was done using 10% KOH, gram stain, and culture were done. Positive culture was defined as growth of same organism on 2 or more liquid medium or confluent growth on 1 solid medium. So we also instituted intravitreal antibiotics. PPV was done. Systemic antibiotics were also given. Age, sex, risk factors, time of exposure to risk factors, microbiological profile, treatment details, and final outcome were also documented. So we defined favorable anatomical outcome as attached retina, normal IOP, and clear media. Good functional outcome as BCVA more than 360 and ambulatory vision. Statistical analysis was done, chi-square test for univariate analysis. Descriptive statistics were also defined, and significance was kept at p less than 0.05%. So in the demography, as you can see, male and female were almost close to each other, 57 and 42%, and there was no difference in laterality with 10 and 11. The most common risk factor that we found was fever in 38% of our patients, and there was no risk factor seen in 42%. We do not find any significant risk factors. 1 to 60 days were the time to end off from the inciting factor, and the final follow-up were 3 to 72 months. Microscopic smear examination, 15 patients gave negative report, whereas bacteria was the most common with 8, and fungus were recorded in 2 patients. Streptococcus pneumoniae was documented in 6 patients, which was the most common, and we did not get any growth in 11 patients. So the good functional outcome with a vision of more than 360 was achieved in 33%, while a favorable anatomical outcome was achieved in 71% at a mean follow-up of 3 to 72 months. So this is a sample of our case of a fungal endogenous endophthalmitis aspergillus. You can see the pre-op B scan, and the corresponding the hyperechoic lesion is seen clinically also in the pre-op fundus image. This was an interesting case, even though not part of the initial data set I presented, which presented to us last month. This is a case of Serratia marcescens with pink hypopyon. This is the intra-op image, and the post-op fundus image with silicon oil in situ. So the mean age of presentation was 6.4 years. Male preponderance were reported elsewhere, but it was equal in our study, male and female. There was no difference in laterality, even though some reports have showed right eye twice likely to be involved because of the direct connection to the carotid. One patient had a history of chicken pox. Even though direct causation is not defined, it could be due to the breakdown of blood ocular barrier. One patient had dengue fever, which is also a similar case. A single case has been reported by Padmanabhan et al. They have also defined the same as a breakdown of blood ocular barrier. Streptococcus pneumoniae was the most common in our study with 28.6%. Most articles have published gram-negative as the commonest. So for the first time, we are reporting in pediatric endogenous endophthalmitis, Pantoia agglomerans, usually seen in fruits or vegetations, rare in humans, known to cause a few cases of endogenous endoph, but not in pediatric age group. Burkholderia cepaceae, there is one case has been reported, that too just an endogenous endoph in a 33-year-old male. The child who presented to us also had the history of IV fluids. Alternaria fungus, only one case has been reported in PubMed so far, that too an endogenous endoph, but not in pediatric age group. So 20 out of our 21 patients underwent vitrectomy. So vitrectomy prevents radical procedures like evisceration or progression to panophthalmitis later. So that is why vitrectomy is preferred. Prompt vitrectomy leads to removal of the infective load, endotoxins, exotoxins, and vitreous membranes in the infected eye. 71% in our case had anatomical success, while 33% had improved visual outcome. So case selection in opting for PPV, Maitre et al. Sir, they had published a study in which they selected patients very selectively. So delay in diagnosis, use of inappropriate antibiotics, gram-negative organisms, panophthalmitis can cause poor prognosis. So to conclude, diagnosis of pediatric endogenous endophthalmitis still remains elusive and challenging. We have reported 3 new organisms, and vitrectomy is definitely beneficial, and focus should be on preventing the potential risk factors that cause pediatric endogenous endophthalmitis. Thank you.
Compared the pediatric with the adult population, also taking it from the review of literature, what differences were there in the outcome and what presentation also?
Yes, sir. After this, we had submitted for AIOC. I have recruited 14 more cases. So we have 30-something cases now, which we are writing it up and analyzing. So probably we can use that to compare with the adult population like you suggested.
Your cases.
What form of treatment did you put them on after the vitrectomy in the unusual cases with Burkholderia?
Based on the sensitivity, antibiotic sensitivity of the specific organism, as directed by the microbiology department, we started them on IV antibiotics as well as injectables, if the injectable is available in the our armamentarium.
What about steroids?
Steroids we did not give.
Okay.
Thank you.
Will please.
Good morning, everyone. I'll be presenting on safety and efficacy of suprachoroidal triamcinolone in retinal vein occlusion. So we know that macular edema in retinal vein occlusion is due to obstruction and retinal hypoxia. The hypoxia upregulates the level of VEGF, which leads to macular edema. So to address this primary problem of increased VEGFs, the treatment options are targeted towards reducing the level of VEGFs. So we have various anti-VEGFs and some recent ones also, and the response is clinically acceptable. In the past, various steroid injections into the vitreous cavity were used to be given, like IVTA, but cataract and glaucoma was the main concern, and which led to development of these steroid implants like Ozurdex, but we all know the cost is on the higher side. So recent studies, they address to this problem, and on the outcomes of depot steroid injection of triamcinolone into suprachoroidal space have shown favorable results in terms of improved efficacy, lesser side effects, and longer duration of action like the steroid implants. Some of the landmark studies like the Tanzanite study, which they have used suprachoroidal triamcinolone in combination with anti-VEGF agents with good results as compared to anti-VEGFs alone. So with this, this fact is established that this is definitely a recent addition to the therapeutic armamentarium of a retinologist, and triamcinolone drug is commercially available at a very reasonable rate. But the only hurdle is that the microneedle or the catheter for injection is not widely available out of the clinical trials. So all these microneedles and catheters, they are patented. So we lack the real world data on the use of suprachoroidal triamcinolone. So to tackle this issue, we modified a 26 gauge needle along with the sleeve of a 22 gauge intravenous cannula for safe and cost effective delivery of suprachoroidal triamcinolone. So this was a retrospective chart review of 20 patients who were treatment naive, and they were treated with suprachoroidal triamcinolone. The visual acuity was worse than 612, and they had macular edema based on OCT more than 300 microns. Known patients of glaucoma and other retinal pathology were excluded, and the follow-up of less than 6 months was also excluded. So to inject the drug, which I'll show you in detail in the video, we take this 26 gauge needle and the outer sheath of this 22 gauge cannula, so that only the bevel tip, which is roughly around less than a millimeter, remains exposed, and it reaches only till the suprachoroidal space. And like any other standard injection procedure, the drug can be injected effortlessly. So this is a short video.
We have used inexpensive intracath and a 26 gauge needle to give suprachoroidal injection effectively. So you can see we, with the help of a scissor, we cut the sleeve of the intracath to almost half the length, and then we put it as a sleeve on a 26 gauge needle, and it goes freely into the needle. But you have to take care that terminal 1 millimeter of the needle should be exposed outside.
Calipers. Because if the beveled end is partially covered, then it will lead to extravasation of the.
Like for any standard
we have
injection
the
procedure,
injection.
we put a drop of betadine and we mark 4 millimeters from the limbus.
We inject triamcinolone. The
and
only
after
other
putting
precaution
we take this needle, we have to keep the needle perpendicular to the sclera, and we have to apply gentle pressure so that there is a
small dimple
slight dimple is formed, and effortlessly
and
you
then
can
the
inject
can be given.
the drug in the suprachoroidal space, and we have used.
In this retrospective study, there were total 20 patients with a follow-up of 6 months. The mean age was 49.45 years, and 70% were males. Based on presentation from onset, 45% presented within 1 month, 30% less than 2 months, and 25% less than 3 months. The baseline visual acuity improved from logMAR 0.75 to logMAR 0.36 at 6 months. This is a chart which shows visual acuity improvement. And similarly, there was corresponding reduction in the central macular thickness. The baseline CMT reduced from 454 microns to 285 microns. The re-injection criteria was a reappearance of macular edema with CMT of more than 300 and best corrected visual acuity worse than 6/12. So almost 1/3 of the patients, they required a retreatment. In these patients, intraocular pressure was also checked immediately after the procedure. The only relevant thing we found that immediately after the injection, the intraocular pressure used to rise, but subsequently within an hour and definitely in all the patients within 1 day, it used to come down, and there were no patients with raised IOP after at the end of the follow-up period. And on subgroup analysis, we found that BRVO had better final visual acuity, and initial visual acuity and CMT were determinants of good final vision. Safety-wise, there were no major concern except transient pain and redness. There was no significant change in the intraocular pressure. These are some of the multimodal imaging and some of the cases which were treated, which shows effective clinical outcome. There is another case where little amount of drug is extravased into the subconjunctival space, but the clinical effect is complete. Thank you.
You are injecting anterior to aura.
Yes, sir.
Over the ciliary body.
Yeah, it's actually it is supraciliary in various trials also, like Tanzanite trial and all the trials. That is the distance they have used, and then it diffuses posteriorly because the space is open. So whenever we are injecting, the beveled end should be posterior so that the drug diffuses posteriorly, sir.
So in sometimes if we inject intravitreal triamcinolone, we use. So there have been cases of reported endophthalmitis. So we just go in and remove the triamcinolone which is present. Is there any way you can remove this from that place? If there is a this uneventful happening happens.
That I think would be very difficult, sir. I have never come across a case reported or in my series that they developed infection. But in case they develop an infection, that would be difficult to reach that space.
Now, how do you know it is supracoronary?
Sir, one is because the location of the space is at that depth. Then subsequently in some of these patients, we have done OCT, anterior segment OCT also, which shows opening of that suprachoroidal space. And in various trials also, they have compared the axial length with the amount of depth of suprachoroidal space. So generally, if the axial length is normal, then that space lies around 800 microns to 1200 microns, which is the length of this beveled end, sir.
Dr. Avdesh, you showed one case of VMT also.
Sir? Yes, that is an interesting case of BRVO.
Do you think that also improved?
Wherein the initial marker, the subfoveal detachment, which is because of the acute inflammatory process, because of BRVO, that settled completely. But those cysts, they appear that they have increased because of the traction. So they have that tractional component and it will need a surgical intervention in that case. But the subfoveal detachment, which is there, that has totally disappeared, sir, which is a marker of good response.
To me in Turson syndrome in a tertiary care center in South India. I have no financial interest. Turson syndrome is defined as intraocular hemorrhage in the setting of acute intracranial bleed resulting in an acute elevated intracranial pressure. So treatment options include observation in mild cases which can result in spontaneous resolution and vitrectomy in cases which cause significant visual loss. So due to associated systemic morbidity, there can be a delay in the diagnosis of the ocular hemorrhage and also a delay in the surgical intervention in the setting of a non-resolving vitreous hemorrhage. The aim of our study was to analyze the outcomes of vitrectomy in non-clearing vitreous hemorrhage in Turson syndrome, also analyzes the association between baseline visual acuity, etiology, age, and timing of surgery to the final visual outcome. This was a retrospective chart review of the EMR cases of consecutive patients diagnosed with Turson syndrome from January 2014 to January 2022 at Giridhara Institute, Cochin. All patients with non-resolving vitreous hemorrhage associated with Turson syndrome who underwent pars plana vitrectomy during the same period by 5 different surgeons were included in the study. The patients with other potential causes of ocular hemorrhage, including ocular trauma, orbital fractures, diabetic retinopathy, or any proliferative retinopathy predisposing to ocular hemorrhage, were excluded. So the patients were examined at 3 different time points at the time of diagnosis, 1 month post vitrectomy, and 3 months at 3 months follow-up post vitrectomy, or the last follow-up, whichever is later. So the examination included best corrected visual acuity in Snellen's converted to logmer, intraocular pressure, fundus examination, and in patients with no fundus view, B-scan ultrasonography. Other parameters analyzed include age, sex, etiology of intracranial bleed, timing between intracranial bleed and vitrectomy, and any surgical complications. So the outcomes measured include the change in baseline visual acuity, visual acuity from baseline to last follow-up, and also the association of final visual acuity to the timing of surgery, age, and etiology of intracranial bleed. So after a well-written informed consent, the patients who underwent 23 gauge or 25 gauge pars plana vitrectomy were included, and additional procedures like endolasers were performed as per indication in the surgical table. So then the patients were followed up 1 month and 3 months. The results, 33 eyes of 31 patients in the age group of 22 to 73 years were analyzed, out of which 12 eyes of 10 patients underwent conservative management, 3 eyes of 3 patients were advised surgery, which was not performed, and 18 eyes of 18 patients underwent pars plana vitrectomy. So these are the baseline characteristics of patients who underwent pars plana vitrectomy. It included 18 eyes of 18 patients, of which 14 were male, 4 were female. And the mean age was 46 plus minus 13, with the age range of 24 to 73. Baseline visual acuity was 1.89 plus minus 0.5. And mean time of surgery after intracranial blade was 108 days plus minus 65, with a range of 24 to 273. And the mean follow-up period was 5.8 to plus minus 1.2 months. So coming to the improvement, change of best corrected visual acuity, the baseline visual acuity had significantly improved with a p-value of 0.001 during 1 month follow-up post-vitrectomy, and it was maintained up until the last follow-up. So coming to the etiology and visual outcome, most patients, the 10 patients with the intraocular hemorrhage with traumatic etiology and 8 patients had aneurysmal bleeds, out of which 4 patients had anterior communicating artery aneurysms, 2 patients MCA aneurysm, 1 patient internal carotid artery aneurysm, and 1 patient vertebral artery dissection. Both the groups showed statistically significant improvement in visual acuity post-vitrectomy, but the difference between both the groups were non-significant. The timing of surgery, 7 patients underwent vitrectomy less than 90 days and 11 patients more than 90 days. Both groups showed significant improvement post-vitrectomy, but the difference between both the groups were non-significant. The age group, 10 patients were less than 50 years of age and 8 patients were more than 50 years of age. Though the less than 50-year-old group slightly performed better than the more than 50-year age group, there was no difference between both the groups. So this was a summary of all the 18 eyes of 18 patients who underwent vitrectomy and the procedures. Most patients had undergone ILM peeling also because of a sub-ILM bleed or an elevated ILM seen. And one patient, labeled 13, case 13, had a epiretinal membrane seen. But this patient underwent vitrectomy after 273 days post the intracranial bleed. However, the final visual acuity was 0.2, which was a significantly good visual acuity compared to the baseline acuity. To conclude, there was significant and dramatic improvement in visual acuity 1 month post-vitrectomy, and the presenting visual acuity may not be a useful prognostic indicator to assess the final visual potential. And according to Garweg et al., which was an old study, the visual outcomes were superior if the vitrectomy was performed less than 90 days from presentation. And in our study and several other studies, similar visual outcomes were seen in both the groups. The etiology and age did not seem to be associated with the baseline or the final visual outcome. Though vitrectomy could improve the quality of life of patients, it is fairly safe for the surgeon to wait for the systemic status to, if the systemic status is unstable, for surgical intervention. So this Terson syndrome, being a rare syndrome, is limited by the sample size of our study. And surgeries were performed by 5 different surgeons, so that limits the procedural standardization. And due to neurological comorbidities, many patients were lost to follow beyond the 6-month period, and this limits the long-term analysis of these patients. Thank you.
So again, a nice paper. I would like to know how many patients were bilateral?
Bilateral in the group which had surgery, there were 3 patients who had bilateral disease.
So in those cases, you have to go in early or just waited for
The other eye had fairly good vision, so they were managed conservatively in those patients.
And second thing, how did you find any difference in the vitreous hemorrhage in Terson syndrome and the other causes of vitreous hemorrhage?
This patients, as seen in the studies, most patients had a sub-ILM bleed and an elevated ILM, which was very different from the other cases of, which was not like probably in a diabetic patient who would have a...
How much was the percentage of the ILM, sub-ILM bleed?
Most of the patients, almost out of 18 eyes, almost 15 eyes had sub-ILM bleeds.
So there's, I think this sub-ILM bleed is a characteristic in a Terson syndrome case. And also another thing is that the hemorrhage is little thicker as compared to the normal hemorrhage which we see in diabetic vitrectomies, right?
Would you consider doing YAG laser for these patients?
Most patients had a breakthrough vitreous hemorrhage also, so that would prevent as hyaloidotomy. If the patient had a clear vitreous, it could be done.
But you all didn't do it for any patient?
No, none of this patients underwent YAG.
Any patient had 27 gauge in this?
No, none of them had 27. Only 23 or 25. Thank you.
Next presentation is by Dr. Manav Jyoti Burman. He will be presenting on hydrogen sulfide as a biomarker in diabetic retinopathy, comparative analysis with VEGF and systemic factors. Manav Jyoti, please.
It's not showing here. अपलोड किया था मैंने कौन सा मानव ज्योति बर्मन बोलता हूँ कहाँ पे करा वही उस प्रीवियर रूम में किया था है नहीं तो पेंडेट से करना पड़ेगा उधर डालना पड़ेगा इधर
Good morning. So I'm going to speak on hydrogen sulfide as a biomarker in diabetic retinopathy, a comparative analysis with vascular endothelial growth factor and systemic factors. So this is a research proposal supported by Indian Council of Medical Research. So background of the study, hydrogen sulfide, as you know, it is a highly active gastrotransmitter along with carbon monoxide and nitric oxide, and it has multitude of physiological role in mammalian tissue like neuromodulator, antioxidant, anti-apoptotic, anti-inflammatory, and vasoactive properties. So endogenous hydrogen sulfide is produced in mammalian tissues and including retina by complex enzymatic reactions, different pathways. So it is a bifunctional role, unlike other gastrotransmitters. It has a protective role in physiological level, whereas it is cytotoxic at the higher level. So overproduction may lead to beta cell death in diabetes and may affect vascular endothelium, and its distribution and role in retinal tissue is still controversial. So we have such literature and the multiple studies are there, though there are very few in human eyes, and only there is no any study comparing VEGF with H2S in different severity of diabetic retinopathy.
So objective of our study is to quantification of hydrogen sulfide level in serum, aqueous, and vitreous, along with vascular endothelial growth factor in different severity of diabetic retinopathy, like NPDR of different severity and mild, moderate, and severe NPDR, and also to correlate it with age-range normal population, and to correlate with other systemic factors like blood sugar and other relevant systemic factors. So, coming to methodology, we collected treatment-naive patients of diabetic retinopathy without systemic complications and scheduled for anti-VEGF injections with prior informed consent. And non-diabetic patients scheduled for macular hole surgery, ER removal, and planned SFIL were considered for control group. And systemic conditions like blood sugar, hemoglobin percentage, lipid profile, renal function test, blood pressure, and BMI were assessed and were standardized to comparable level. We excluded patients with uncontrolled hypertension using hyperlipidemic drugs, oral anticoagulants, contraceptives, everyday smokers, renal failure, and cases using ACEI and patients undergoing PRP. So these are the different clearance, ethics committee, research committee, and biosafety committee clearance for the study. And these are the consent from standard consent form of patients. So we collected 150 patients. Out of this, 50 was NPDR, 50 PDR, and 50 control groups. Out of the NPDR, 16 were mild, 20 were moderate, and 14 severe NPDR. So sample collection was done, aqueous humor was collected by 30 gauge tuberculin series and by AC-type, and vitreous sample was collected by a single port 27 gauge scatter during intravitreal injections, and serum was extracted as per standard laboratory procedure from whole blood. So S2S analysis was done on the day of collection within 4 hours by spectrophotometry, and VEGF analysis was done by ELISA test. So statistical analysis was done using standard statistical test, and p-value less than 0.05 was considered statistically significant. So coming to results, so these are descriptive statistics of patient parameters like age, BMI, hemoglobin, serum creatinine, cholesterol, TGL, lipid profile, and blood sugar. So there is not much variation in the group. And this is H2S and VEGF level in the different groups like vitreous. We recorded H2S from 55 to 64. Aqueous, it was 53 to 63 in different severity of diabetic retinopathy. And serum, it was 54 to 61. And VEGF, it was 165 in control to 819 in PDR group. And serum, it was 154 to 321, depending upon the severity of diabetic retinopathy. So these are the box plots and bar diagrams showing corresponding levels of the H2S and VEGF. So this is a comparison of the mean H2S and VEGF shows that there is a significant variation in the H2S level in control versus severe NPDR and control versus PDR, whereas vitreous and serum VEGF shows variation in all the groups. And this is the correlation of H2S and VEGF level with other systemic parameters. We could see only strong correlation between blood sugar level with different grades of severity of diabetic retinopathy, and very weak correlation with cholesterol and lipid profile in the control group. So coming to discuss, experimental evidence shows H2S overproduction as a causative factor in pathogenesis of beta cell death in diabetes. Evidence supports the role of H2S in the pathogenesis of diabetic endothelial dysfunction, diabetic retinopathy, and cardiomyopathy. Contradictory evidence exists on association of H2S and retinal neovascularization, while some studies support that it has certain protective role under retinal vascularization. So, certain studies show it is a harmful effect on the retinal neovascularization in diabetic retinopathy. So we observed higher concentration of H2S in intraocular environment as well as serum in patients with diabetic retinopathy that was found to be comparable with VEGF and blood glucose level in varying severity of diabetic retinopathy. There is weak correlation observed in control group with VEGF and cholesterol in all samples and with H2S level in vitreous sample only. No significant correlation was observed in any of the groups. So contrary to existing literature, in this study we quantified and compared H2S level in ocular and systemic environment in PDR, NPDR, and non-diabetic control population with corresponding levels of VEGF, status of blood sugar, and other systemic parameters. So coming to conclusion, current study aids some insight about the complex pathological process of diabetic retinopathy and role of H2S as an independent biomarker in the process, which may form some basis of further study. There is scope of research to explore significant H2S in complications related to diabetic retinopathy, which may help to find newer treatment modalities for management of this potentially binding condition. Thank you. So these are my references.
Shankwish? Did you have a control group?
Yes, sir. 50 were control group.
No, what was the control group like? I mean,
control group were non-diabetic people who underwent vitrectomy for macular hole, epiretinal membrane, and SF5Ls. These are non-diabetic people.
no, but why not have control group of diabetics without any clinical evidence of, I mean, diabetic retinopathy? You
So-
think that may also show some changes, basically?
So I divided diabetic patients from mild to severe, but too many groups will create more confusion and statistical analysis.
No, what I'm trying to say is, I don't know, I'm not a great researcher. But then if you want to really try and see whether hydrogen sulfide has got a very, a role, I mean, it may be better to have a control group also of eyes with diabetes with no underlying retinopathy at all.
Yeah.
And probably for that, you will have to do a fluorescein angiography also, because mild microaneurysms may
And
miss.
yeah, one thing more, he's telling already undergone vitrectomy. So how you can take vitreous step also? Everything changes, no?
So we took vitreous step before going for vitrectomy.
Hey, you told that
And in
control group who
diabetic,
already undergone macular hole surgery or other vitrectomy.
those are where we before starting surgery, we took that step. And in also other diabetic patients, we took that step before going for intravitreal injections. And actually, my purpose was to just study the level of H2S in Indian population, basically, and whether it does it correlate with VEGF level? Because studies are showing VEGF level in different category of diabetic retinopathy, but there is no study showing H2S level in diabetic, different severity of diabetic retinopathy.
Okay.
You correlate it with the blood H2S levels?
Yes, sir.
It
Serum
correlates?
H2S and VEGF were calculated in all the patients. But Aquas, in Aquas only we did H2S and VEGF. VEGF was not calculated in Aquas because the sample was not sufficient.
So can it be implicated that H2S is the one which is causing from this? I don't think so.
So both have different pathway actually. That modulates the vascular proliferation and endothelial function. So H2S has a different pathway, and VEGF has a different pathway, and both modulates the vascular endothelial function. So whether they have strong correlation?
No, basically what he's trying to ask is whether it would be worthwhile also to look into the VEGF levels simultaneously along with the hydrogen sulfide levels.
Yeah, we in the same patient
you
we
have gone
analyze
through that.
H2S and VEGF in all the cases.
Yeah.
Only the PDR group shows a very high spike of VEGF in serum, but in H2S group we see some controlled comparable rise. Otherwise, all the groups have a more or less comparable rise in the H2S versus VEGF.
So which is responsible, we don't know.
Which one is how they are working, it is difficult to comment. But because some studies are showing that H2 has in initial stage, H2 has a protective role on retinal vascularization. Whether some studies are showing H2 has a harmful effect on the retinal vascularization, which helps in proliferation.
But I still feel, doctor, you should include. I feel you should include eyes without diabetic retinopathy. Also, I feel so. This is an ongoing project.
No, it is already complete.
Already complete.
So these analyses are very expensive. Every kit costs around 35,000 rupees.
Right, sure.
Yeah. So we.
Okay, thank you.
Thank you.
Next paper is by Dr. Neeraj Kumar Sahu. Is present. Okay. He will be presenting on in-fast optical coherence tomography patterns of closure of idiopathic macular hole.
Good morning, everyone. So I'll be presenting our new developed on-fast based classification of idiopathic macular holes. So the basis behind why we discussed or described this was, if you look at the previously described closure patterns, it's either U, V, or W, or type 1, type 2, or the recently classified based on the bands, continuity of the retinal bands. But all these classifications only talk about a single OCT scan. But considering a macular hole is a 3-dimensional structure, why should we see only a single scan? So this is why we went ahead with the study and to try to determine how these macular holes are closing on-fast OCT. So this was a retrospective study, and we took all the macular holes for the past 1 year, and we used multiple OCT machines to analyze this. The OCT parameters that we analyzed were the OCT pattern of hole closure, and the preoperative hole orientation, either it was round or oval. And we measured all the indices also, like MLD, basal hole diameter, and hole height. We also measured the acircularity to see how the hole orientation is. So this is an example how we classified oval and round holes. You can see the first two are oval holes. One is horizontal and one is slightly oblique, and the third one is a round hole. And the closure pattern, as you can see here, we classified the first one as a linear closure. We can see that small line, and both the below two are linear. One is horizontal, one is oblique, and the third one is an indistinct circular type of pattern. So when we analyze the results, this is the baseline parameters. The mean age was around 63 years with visual acuity of around 1 logmar. There were total of 64 eyes, for which 43 were round and 21 were oval, 14 were horizontal, 4 were oblique, and 3 eyes were vertical. Surgical intervention, 25 eyes underwent ILM peeling with ILM flap or a graft, and 39 eyes underwent ILM peeling alone. Based on the on-fast type of closure, 38 had a indistinct centripetal or round closure, and 26 had a linear closure. 17 were horizontal, 7 were oblique, and 2 were vertical. But when we analyzed it based on a logistic regression, we found that the baseline hole orientation was the only factor responsible for the type of hole closure on on-fast post-operatively. So it means that if a hole is oval, it closed in a linear manner. If it's a round hole, it closed in a round or centripetal manner. So this is how it we suspect, we hypothesize it to be working. So it's a oval hole, the first one. The second was a round hole. The forces, the opposing force is on the axis where the distance is less. So it closes in a linear fashion, while the round closure, round closure is a centripetal type of closure. However, we did not find any difference between in terms of final visual acuity between these two groups. But when we classified them into holes that are more than 650 microns, we found that the linear group had significantly better visual outcome than the round or centripetal group. We can see in the large macular hole group that the round closure group, the linear closure group, had a significantly higher so the p-value, the box is slightly misplaced. Significantly higher horizontal basal hole diameter, but lesser vertical minimal linear dimension. So summarizing, we described different types of hole closure patterns and how it can tell us about the final visual acuity. The pre-op hole orientation determines the type of closure. Holes more than 650 microns, linear closure had a better functional outcome. But future studies will be required to see if there is any relationship between the ILM peeling, whether the flap or graft is affecting it, or the area of peeling is affecting it or not. Thank you.
Did the amount of ILM peel, the area of ILM peel, affect the closure and the kind of closure?
No, the analysis shows that it did not affect it in any way. We measured it post-operatively. That is one limitation. We used the on-fast OCT again to measure the peeled ILM area, but that was very inaccurate. But if a better modality would be measuring intra-op photographs, but that can be done in future studies. Thank you.
Presentation is by Dr. Yash Parmar. He is present. Okay. He will be presenting on arrangement of ocular blood vessels in eyes with fundal coloboma.
Good morning, everyone. I am Dr. Yash Parmar. I'll be presenting arrangement of ocular blood vessels in fundal coloboma. So, retinochoroidal coloboma occurs due to incomplete fusion of the embryonic fissure, and in that, hence, the outer retinal layers are absent, and the inner retinal layers continue as the intercalary membrane. The outer retinal layers can, or the photoreceptors can fold upon itself and are seen at the edge, called as locus minoris resistente. There are two classifications which we commonly use. This is the Edaman classification, where it has been classified into type 1 to 7, where type 1 is above the disc, type 2 is at the upper margin of the disc, type 3 is at the lower margin of the disc, type 4 is the disc coloboma, type 5 is isolated fundal coloboma inferior to the disc, type 6 is the pigmentary coloboma, and type 7 is the peripheral coloboma. The other classification which we commonly use is Lingam Gopal classification, which has classified colobomas into 6 types, in which type 1 to 3 does not involve the disc, and type 3 to 6 involves the disc. However, that classification has not included disc coloboma as a separate entity. So there have been very few studies which have described arrangement of ocular blood vessels in fundal coloboma. One was by Casper and other was by Lingam Gopal sir. But they described only the retinal blood vessels which were going through in the colobomatous area. They did not describe the choroidal blood vessels and the vortex vein in the extra colobomatous area. So we found this interesting finding in our clinic, and hence we went ahead with this paper. It was a retrospective observational cross-sectional study with 69 eyes of 45 patients. Ultra-wide field fundus photo, optos photos were available for all the patients. FFA and ICG was available for a limited number of these patients. So what we looked for is the origin of the retinal blood vessels from the disc, their course into the coloboma, whether retinal artery and vein were present inside the coloboma, extra colobomatous area, whether they had dilated tortuous choroidal vessels and vortex veins, and also this interesting finding of these dark vessels, which was initially thought to be choroidal vessels, but choroidal vasculature is not present in the coloboma, and these are episcleral vessels which are seen. This was shown by Lingam Gopal paper also. So these are some examples. This patient has type 4 and type 7 coloboma, and we can see that the vessels are arising from the disc margin. There is this dilated vortex vein and choroidal vessels. There is the continuity of these retinal vessels in the coloboma is not traced, and we can see the dilated episcleral vessels on ICG. This is another example of type 1 coloboma. The disc is not distinguished very well, and we can see the dilated choroidal vessels. The course is not very good, and we can see these episcleral vessels. So 25 males and 20 females were included in the study. 24 eyes had bilateral coloboma. Mean age was 36 years with the age range of 6 to 76 years. Visual acuity range from 6.6 to counting finger half meter. A maximum of 3 coloboma was seen in one eye. 78 colobomas were included. 65 were retinochoroidal coloboma and 15 were optic disc coloboma. So this is the table depicting the various aspects. The overview is that the type 1, 2, 3 and 7, which are basically the large colobomas, did not have the vessels, the retinal vessels in these colobomas did not have a continuity with the vessels arising from the disc and also in the extracolobomatous area. They had lesser number of vortex veins and significant episcleral vessels seen in these choroidal colobomas. Whereas the small colobomas like 4, 5 and 6 had the normal number of vortex vein. The episcleral vessels were not that commonly seen, and the continuity of the retinal vessels inside the coloboma could be traced easily. So the previous knowledge is that there are very few studies in accordance with Lingam Gopal et al. We found that retinal blood vessels can be seen in the choroidal coloboma in spite of the absence of RP. Hence the VEGF and vasculogenesis should not ideally be there, but we can find retinal blood vessels in the coloboma. Choroidal blood vessels are not seen, and these deep episcleral vessels are seen, which is confirmed on ICGA. Our interesting finding is that type 1, 2, 3 and 7 have prominent choroidal vessels. The continuity is poor in these types. The deep episcleral vessels are more commonly seen, and overall the vortex veins seen in these patients are lesser in number, probably because the choroidal vasculature is less, hence the drainage is lesser, hence they become atrophic or get collapsed. So the strengths of our study is one of the few studies, the sample size is better, and there is a better understanding of the vasculature in these studies, as in we've studied the choroidal vasculature and also the vortex vein. Limitations were that the FFA and ICG were not available for all patients. Axial length measurement was not done for all the patients. So in conclusion, coloboma eyes do have variation in the arrangement and distribution of ocular blood vessels. Position, size, anterior posterior extent are the primary determinants of these variation. Though this is a descriptive study, it will help in surgical planning and laser for these patients. But future studies with better ICG will help. These are my references. Thank you.
Thank you. That was a very nice presentation. And any questions?
Surgical management.
Yeah.
Now, in what way will it help the surgical
Sometimes in retinal detachment, there are taught ICM. So sometimes we have to give a relaxing retinotomy cuts on these ICM. So if we can trace the vessels well and see their origin, we'll tend not to cut it.
Thank you.
Okay, thank you. The next presentation.
We tried to study the patterns of retinal and choroidal neovascularization in type 2 macular telangiectasias. There were no financial interests involved in conducting this study. Macular telangiectasia type 2, as we know, is a disease of the retinal vasculature, which it has been divided into the non-proliferative and the proliferative stages. The non-proliferative stages are the Gassenblody stages 1 to 4, whereas the proliferative stage is the Gassenblody stage 5, which has classically been described to be associated with subretinal neovascular membranes. But is this so characteristic? There have been recent reports suggestive of association of macular telangiectasia type 2 with non-subretinal neovascular membrane patterns of neovascularization. And why is this occurring? So, to study the neovascular patterns and clinical features in the patients diagnosed with macular telangiectasia type 2 in our set of patients was the aim of our study. So we did a retrospective analysis of our group of patients who were diagnosed cases of neovascular type 2 macular telangiectasia, and patients in whom enhanced depth images were of poor quality or were not acquired were excluded. Ultimately, a total of 42 eyes were included in the study, and these patients were further grouped into two categories. Group A included patients with the classical subretinal neovascular membrane, and as well as the patients with silent neovascularization, and whereas group B included patients showing other forms of neovascularization. Now we studied the demographic characteristics, the clinical features, the angiographic features of these patients, and on optical coherence tomography we looked for the dilated choroidal vessels, and the choroidal thickness in these patients was measured using the inbuilt caliper tool of the Heidelberg Spectralis software. Two independent observers noted the findings, and the data was analyzed using Microsoft Excel and the statistical package for social sciences softwares. Coming to the results, in our set of patients included in group A, we found the classical subretinal neovascular membrane pattern in 31 eyes, whereas silent neovascularization was seen in 5 patients. Silent neovascularization was defined as absence of neovascular activity but in presence of a retinochoroidal anastomosis. In our patients in group B, we found 4 cases of polypoidal choroidal vasculopathy, whereas pachychoroid neovasculopathy and retinal angiomatous proliferation was present in 1 eye each. Coming to the gender distribution, most of our patients in within groups as well as overall were predominantly females. So, looking at the comorbidities, diabetes mellitus was more frequently seen in patients in group A, whereas in only 1 patient in group B, whereas hypertension was seen more frequently in group B compared to group A. The mean age of our patients was higher in the group B compared to group A, and the mean choroidal thickness was also marginally higher. However, both these values were not statistically significant. Dilated choroidal vessels were seen in 83.3% of patients in group B, as against the 55.5% patients in group A. However, this difference was also not statistically significant. These are few case examples in our study. The first image showing a fluorescent angiography image showing a perifoveal leakage with a corresponding clinical photo showing a pigmentation at macula. The other eye of this patient had a hyper surrounded by hypo pattern characteristic of polypoidal choroidal vasculopathy. The next image is a case of Mactel who presented with hard exudates in the foveal region. This patient was ultimately diagnosed to be pachychoroid neovasculopathy. The third image is last image is a characteristic hairpin loop seen on indocyanine green angiography with a trapezoid pigment epithelial detachment suggestive of retinal angiomatous proliferation. So to summarize the results, female gender was more predominant. Diabetes was seen less frequently in group B, whereas hypertension was more frequently seen. Choroidal thickness was similar in both groups, and the mean age of group B was higher. And dilated choroidal vessels were seen more frequently in group B, and the difference was not significant in any of these characteristics. Various studies have indicated the neovascularization in MACTEL originates from the retinal vasculature. However, Zhang et al. In the study of OCT angiography concluded that subretinal neovascular complexes may also be connected to the choroidal vasculature. So, an extension of the neovascular process to the choroidal circulation is probably what we are seeing in our pachychoroid set of patients in group B. Pachychoroid pattern of neovascularization was predominant in our group, and Shablani et al. Had also tried to analyze the choroidal thickness in patients with MACTEL, and the differences in choroidal thickness were not significant in their finding as well. And our group of patients, however, is very small to come to any solid conclusions. Yanuzzi et al. Found similarities between the pathogenesis of retinal angiomatous proliferation with neovascular macular telangiectasia. What they say is that as a compensatory mechanism to perfuse and drain the angiomatous lesion, the proliferation is seen in the deep capillary circulation, and this proliferation extends beneath the retina to form the subretinal neovascular membrane. The patients in RAP are often of a higher age group, and this is consistent with our findings. So to conclude, as MACTEL progresses, an array of changes occur in the retinal and possibly the choroidal vasculature, and the occurrence of pachychoroid features in MACTEL may be yet another unexplored lacuna. And the small sample size was a limitation of our study, and we need further studies to investigate this further, whether any atypical neovascularization is associated with these patients.
Any questions?
Now there is a last presentation by Jharkhand Ophthalmological Society. Is Dr. Neda Ahmede present? Okay. She will be present. Neda, please.
Okay. Good morning. Myself, Dr. Neda Ahmedi, and I'll be presenting on the topic, Has COVID-19 pandemic given a spurt in retinal vaso-occlusive disorders? There's no financial interest. Retinal vaso-occlusive disorders are one of the commonest sight-threatening vascular events. Mechanism could be atherosclerosis, hypercoagulability, vasculitis, or a combination of all. The various risk factors include systemic hypertension, cardiovascular diseases, advancing ages, hyperlipidemia, diabetes, etc. Now it is known that SARS-CoV-2 virus induces a hypercoagulable state, which leads to thrombus formation and stasis, plus it causes vasculitis and endothelial dysfunction due to the cytokine storm. Therefore, satisfies the virtuous triad, which is the pathogenesis of occlusion. So my aim was to find association between COVID-19 and retinal vaso-occlusive disorders. It was an observational case study of 1 year duration conducted between September 2020 to 2021. All the newly diagnosed cases of retinal vaso-occlusive disorders were included, and patients with blood dyscrasias, diabetic and hypertensive retinopathy, malignancy, posterior uveitis, chronic kidney diseases, retinal inflammatory disorders, and history of trauma and surgery were excluded. A total of 33 cases were taken up after satisfying the inclusion and exclusion criteria. Written informed consent was taken, medical records were retrospectively viewed, and history was taken for COVID-19 status. Participants underwent a standardized evaluation consisting of questionnaire, ocular examination like best-corrected visual acuity, fundus examination, OCT, FFA, and various routine investigations and some specific like D-dimer, interleukin-6, ferritin, etc. Coming to the results, sex distribution did not show any predilection. Mostly older age group were affected, although 6 cases were reported under the age of 60 years, and 5 out of these were COVID infected. Type distribution showed maximum cases of branch retinal vein occlusion. Here, figure 1 shows that out of total 33 cases, 16 had history of COVID-19 infection, while 17 did not. Figure 2 shows that in these 17, upon antibody testing, 6 turned positive. Therefore, total COVID-infected patients were 16 plus 6, that is 22. So 2 groups were made, group 1 with COVID infected and group 2 non-COVID infected, and the specific investigations were compared like CRP, ferritin and LDH, which are the inflammatory markers, and they were found elevated in the COVID group. The most important in them is the D-dimer level, which is related to the thromboembolic phenomena. The mean D-dimer level in the COVID group was 971 and in the other was 152. By using unpaired t-test, the two were compared and the differences came out to be significant with a p-value of less than 0.001. So this study highlights few important points. Firstly, the number of cases at our hospital has increased as compared to last 3 years. Secondly, 6 cases were found under the age of 50 years, which is rare. Similarly, Cavalcanti et al. Also reported cerebral thrombosis in 3 young COVID-infected patients. And thirdly, the mean D-dimer values, which was 971 in COVID-infected patients, and such elevated D-dimer levels indicate high propensity to develop blood clot. This fact is strengthened by a case report of Venkatesh et al., which shows improvement in the visual acuity and macular edema after reversal of the hypercoagulable state. Although there may be a synergistic effect of the pre-existing risk factors and the COVID infection, but 8 of our cases did not have any known risk factors. Also, Linker et al. Reported a case of 17-year-old girl who presented with post-COVID CRO in absence of any known etiology. Thus, I would like to conclude that increasing number of cases, increasing incidence among younger age group, increased D-dimer levels, and occurrence of disease without any known etiology, all this converge to the fact that yes, there exists a correlation between the two. Since it is known that COVID-19 affect multiple organs, and as it is rightly said that eye is a window of systemic diseases, therefore, in such a scenario, our approach should be comprehensive management of a patient of RVO, thereby correcting the associated disease and the predisposing abnormalities. Clinicians must be aware that visual symptoms may occur even with milder form of systemic viral infections, and therefore preventive measures like thromboembolism prophylaxis and extended prophylaxis in some selected cases must be taken. Plus, careful assessment for the incident thrombotic event must be done so that patient do not land up in some life-threatening complications like pulmonary embolism, stroke, etc. These are my references. Thank you.
That was a very nice presentation.
Thank you.
And you're lucky because of lack of time, we are not going to ask you any questions. So you can go. And over to the other people. And thank you all my co-chairman and whoever's on the dais for being with me on this session.
At the beginning of the session. So we lost about 5 minutes.